A pregnant woman suddenly gives birth in your emergency department, and the baby is blue. You remember to check the airway, warm, dry, and stimulate the baby, but there is no change. Let's be honest, this is terrifying, but no need to panic. We got you covered with the head to toe approach. Let's start with our goal for the resuscitation, which is a heart rate over 100. Heart rate is a good indicator of how well a newborn is doing. Keep in mind that a baby's normal heart rate is much higher than adults or child, so it should be at least 100. Anything less probably means that the newborn is decompensating. You might be wondering how to check the heart rate. You have probably heard that you can check it at the umbilical base, which is true, but a more reliable way is to just listen to the heart with your stethoscope. You can also connect a pulse oximeter to the baby's right hand, which is preductal. The pulse oximeter won't be immediately accurate for heart rate though, so listening is still the best. If a patient was just born, it's important to know that the oxygen situation won't be normal immediately. So now that we know our goal, we need to know how to get there. If your heart rate is under 100, start at the head, specifically the mouth, by administering breaths with a back valve mask for 30 seconds. If the heart rate is still less than 100 with good ventilations, you should intubate the newborn. Remember the phrase 3.5 at birth. A full-term newborn usually weighs 3.5 kg and gets her 3.5 uncuffed tube. At this point, the heart rate will usually either go up if the patient improves or down if the patient worsens. If the heart rate doesn't increase, we move on to the chest in the head-to-toe approach. After 100, 60 is our second magic number in newborn resuscitation. A heart rate under 60 in a decompensating child is considered the equivalent of cardiac arrest in an adult, and you should start chest compressions as detailed in the CPR video. As a quick reminder, use 3 compressions followed by 1 breath in between compression cycle for a newborn. If the baby doesn't improve with chest compressions, we move on to the belly in the head to toe approach. If the heart rate is still under 60, it's time for epinephrine. The easiest place to administer epinephrine is an umbilical line. If your nurse has been able to place an IV, just use that. Or as an alternative, you can place an interosseous line. Finally, we move down to the toe, which should remind you to check the glucose level. If you don't have an IV in already, you can do a heel stick. If the neonate is hypoglycemic, which is under 40 milligrams per deciliter at this age, administer 20 milliliters of D10. If you want more specifics, please watch the deathstroke administration video. Now that you're familiar with the head-to-toe approach, you can be more confident when a baby is born blue in front of you. No need to be terrified. Well, maybe a little.